A couple of caveats about this discussion. This is fairly comprehensive, but it's also a moving target. So if you see my asterisk there that says info could be outdated very quickly, and see Medicare.gov and Medicaid.gov for the latest changes that are ever occurring in our medical landscape. So, and I also want to thank Kate for some of her slides, which I imported into here to give nice visual breaks as well as an overall schematic of what I'm going to talk about. So what am I going to talk about? Well, the title is Proactive and Preventive Care for Older Adults in the Second Decade of the Affordable Care Act. And that's a lot of stuff to go over, but I realized that there are some basic principles that all of us as geriatricians and people interested in the care of older adults would like to cover. So first, we'll briefly review the Affordable Care Act initiatives that stimulated proactive and preventative care relevant for older adults, discuss those initiatives in the context of key Geri syndromes, in this case, depression and cognitive impairment and falls, and then review a little bit about how ACA initiatives have impacted classic preventative care screening, such as statins for primary prevention, et cetera, and then discuss where all of these ACA initiatives fit as Medicare heads to value-based care. The other caveat I want to say is a lot of our patients are Medicare, Medicaid. We won't really cover that except to say we all know that Medicaid covers pretty much all of the gaps in Medicare. So, but if there's specific questions about our dual eligible patients, please let me know. Okay, so Medicare eligibility, as you all know, comes in several flavors, not just age, but also folks that have amyotrophic lateral sclerosis, end-stage renal disease, and then those that qualify for disability and have had disability for at least 24 months and receive Social Security disability benefits also receive Medicare. So it's all encompassing, and then there's special groups that are added on. And I think that that's always tricky for us, but it's something to keep in mind, especially the dialysis provision that ranges anywhere from immediately to 4 months for Medicare qualification. So the 4 parts of Medicare, and I thank Kate for this slide, just to briefly review, as you know, is Part A is hospital insurance, Part B is outpatient insurance, Part C is Medicare Advantage, which is increasingly prevalent in many urban areas as well as rural areas, which is basically where you're under the provisions that are guided by an HMO or a preferred provider organization and is more restricted, but you benefit possibly on the premiums as well as the deductibles and copay. And then there's Medicare Part D, which is prescription drug coverage. One quick way to remember this is A is in and B is out. So that's how I always remember it, because those are the 2 major groups of Medicare provisions that we have to keep in mind. So A covers inpatient SNF and home health and hospice, whereas B is pretty much limited to outpatient and outpatient provisions for like durable medical equipment. So, I'll start with 2 very different cases. These are from my clinic. We have Mrs. GE, who's 86. She's been in my talk for this for many years. She has treated hypertension, osteoarthritis, stress incontinence, and she comes in for her Q6-month visit and wants everything updated under all her Medicare provisions. Her BMI is 28, her exam and labs are unremarkable, and the question is, what kind of preventative care should she receive? Her best friend is Mrs. EG, and she's also 85 or 86, but she's got poorly controlled hypertension, CKD4, hyperlipidemia, coronary artery disease, peripheral vascular disease. She's very thin. She has stigmata of her comorbidities. Her labs are notable for her comorbidities, and she's very frail. And then the question becomes, what preventative care should she receive? And I think we all appreciate that this is all about that many aspects of preventative and proactive care are about physiology, not chronology. But sometimes it's very difficult to have an idea of how much each patient should get in the way of proactive or preventative care in the context of their age, their comorbidities, and of course, their all important goals of care. So how can you approach that? Well, historically, as you know, we've thought about life expectancy calculators, we've thought about time to benefit, we've talked about a lot of different ways to help our patients prognosticate how much we should do in the way of preventative and proactive care versus just trying to maintain their steady state. And so the classic calculators, as many of you know, have been on ePrognosis for many years, developed by our colleagues at UCSF. And along with those calculators that calculate time to benefit, the big one that they've touted over the years has been life expectancy, but they also have time to benefit and other prognostic calculators like ability to stay independent, et cetera, based on variables that you enter. So we have a lot of information to help our patients in these guidelines. But what's happened is that we have these now provisions through Medicare, through the Affordable Care Act, which many of you remember started in 2010, that sort of set a different tone for what's available, what should be done, and how much of this checklist should I be able to get through in a reasonable, management plan with my patient. So the big one that launched first was the annual wellness visit. So that was launched in 2011. And it's basically a team approach to looking at some key things that geriatric providers know is important: falls, memory concerns, depression, home safety, and a list of other people who are involved in that patient's care, and then some basic vital signs and a check of their gait. So basically things that we realized were, I guess we would say, kind of a broad purview of that patient's overall status. And this is something that we've increasingly made very easy to do in Medicare, in the Epic medical record, but it really does become a typing exercise. And often the patient comes in and you're sitting at this computer filling out this form, and it's really something that, at least historically, used to be a little bit confusing for the patient, because you were typing, you were filling out this checklist, but there's really no physical exam, except, at least not mandated, except for vital signs and then a gait check. You're welcome to do more, and you're welcome to add a modifier 25 for additional things that come up in the visit. But the actual mandate is very much a checklist. So how is the annual wellness visit doing? Well, it suffered, as many of you know, from COVID, though there's like a 3 to 4 year gap in data. But we do know that overall uptake is still less than 30% of all comers. In accountable care organizations, ACOs, the uptake is over half, but it's still quite poor in the general Medicare population. There's increased likelihood when it is done of instituting general preventative care and individualized prevention. And there's also some evidence that there's going to be less spending on groups of patients who do the annual wellness visit on certain hospitalizations and outpatient services. But again, data is really disappointingly lacking on downstream benefits. There's certainly increased screening, especially depression and cognitive screening, but especially for cognitive screening, that might reflect just general attitudes towards increasingly being aware of patients with early cognitive impairment. Patients with chronic illness, though, such as diabetes, might be actually the ones that really benefit from an overall check-in, because their individual visits can be so taken up with just their disease process. So what are the positives and negatives? We don't need to belabor this. You all know it. It allows care coordination. It builds loyalty. You actually get an hour for it, which probably isn't needed. You can add a modifier 25 if you develop any type of pathway into an additional problem that's outside the annual wellness visit scope. And you could do advanced care planning with no copay or deductible, which is a plus for patients. It gets easier with each year, but it can be boring. And again, some things are worth asking each year, but maybe some other things aren't. And it can be difficult to operationalize. It has to be no less than 12 months since the last annual wellness visit. So you want to coordinate it, you want to leave some time for other things, but it still can be a logistic difficulty. Okay, so what are the other things about this? Well, it's here to stay. And we don't know yet what the benefits are going to be downstream, but it's required, especially by ACOs and Medicare Advantage plans. And the financial incentives for hitting certain targets are going to be increasingly prevalent. And those targets are going to be based on doing the annual wellness visit. So obviously there's an industry geared to making sure that this works and that people do it. Okay, so what about some of the other provisions? And please let me know in the chat if you have any questions as we go along.
There is one question. Do you want to save them for the end, or do you want to?
Yeah, let's save them for the end.
Okay.
Yeah, I see that's a very good question. All good questions. And so transitional care management, again, I'm not going to belabor this. I'm going to go through it very quickly. It started in 2013, so it's had its 1-year anniversary, 10-year anniversary as well. And as many of you know, this is a 30-day care management service for patients who have been discharged from a qualifying hospital stay or SNF stay. And it's probably one of the things that has had the easiest uptake. And one of the things we've realized is that TCM Lite might be enough. That is to say, focusing on just the med changes that occur during transitions of care and not going into all of the things, but focusing on med changes and maybe some DME changes, like did you get started on oxygen? The issue has been the 2-day phone call. You have to do a qualifying attempt at a phone call within 2 business days after discharge. And people have found out that if you do that call and go over the med changes and everything, there was very little value in the additional face-to-face visit that is mandated in TCM. So you have to do a face-to-face, either telemedicine, home visit, or in the clinic within 7 to 14 days. And it's not really clear that that's beneficial if you can get through on that phone call and review meds and DME and oxygen and other supplier issues. There is some signal that there's decreased cost in managing patients who have TCM after a qualifying stay, but its uptake is still pretty poor. With less than, the best data I could find was 2023, which of course grabbed in data from 2019, and it had less than around 11% uptake in qualifying Medicare discharges had TCM. Notably, this was a study done a couple of years ago by Leah Marca, is that if you put it in, it gets paid. So if you can get through that note and that 2-day phone call, it does has a very low incidence of denial of payment. Okay, so next, and again, quickly through these, CCM, CCM has been here since 2015, and it's basically a monthly fee that Medicare allows you to charge for care coordination of qualifying patients with 3 or more chronic conditions. It's not the same as care management, which is, nurse management of patient movement through the system, getting their appointments, getting their rides. This actually is a pot of money for taking the patient and each month coordinating their care. The rules, as you know, are chronic conditions that put them at risk for death. Patient has to be consented and is actively engaged in the process. And then you have to come up with a place to put all these documentations, which is really difficult. And that's been a big barrier to institution of this. You don't have to see the patient in person, but there has to be a place in Epic to coordinate the different pieces of chronic care management that allow you to reach 20 minutes per month per patient. And so that's basic CCM. And that is, it can really add up. If you see down at the bottom, and I don't want to belabor the actual amounts, but it can be anywhere from $30 to $45 per month per patient with qualifying 20-minute documentation. Where there's a lot of interest is complex CCM, where you get to 60 minutes, and you can see the amount is double if you can get to 60 minutes, because there was a lot of evidence that med reviews alone can easily take 20 to 30 minutes per month. And I think you all know that that's the case. So what are these two numbers? Whenever I have a number, and that I don't want to belabor the numbers, the first amount is the amount collected per fee for a non-facility place, and that would be, say, a freestanding clinic, where they get a higher amount of reimbursement than the second number, which is a facility-based place like Harborview, where they get a lower amount because they also have a facility fee that's separately billed. And so they get actually less for the actual visit because they also bill for the facility fee. And everyone says, oh, the facility fee is going to go away, but it hasn't yet. So hospital-based clinics do get less per every type of episode of billing that we're going to talk about today. Okay, so how is CCM going? Well, we still have not been able to launch it. Harborview Senior Care Clinic, UW Medicine has been able to launch annual wellness visits and TCM, but CCM has been really difficult. And the uptake across the country has been difficult. And it's been difficult to measure, but it's still in the single digits. It's increasing, but still in the single digits. Why is that? Well, some of it is the monthly copay. So, you're talking about anywhere from $30 to $90 that the patient is the fee per month. And don't forget, under Medicare, they have to pay 20% of that. So not only do they have to meet their annual deductible, but they have to pay a copay each month. That is waived if you're a dual eligible patient, if you have Medicaid or if you have Medicare Advantage. But for the bread and butter Medicare only patient, that monthly copay is like, that's part of the consent process, and it can be a real barrier. There's also a lack of payments for setting this up. And that's been one of our big challenges in senior care clinic. Like, where do we put this in the Epic chart? There are so many folders, and you want everyone's note to drop into a central folder so that it can then be billed at the end of each month. But that is not an easy ask. But there is a sense that if you could just focus on patients who qualify for complex CCM, which is the 60 minutes per month, which is typically a pharmacy-led intervention, because pharmacy time is a big part of the CCM goal, which is managing medications, it can be a win-win. Okay, so along with CCM, though, PCM came about, and we were just like, what is PCM? So PCM was instituted because subspecialists said, hey, wait a minute. I have complex patients, but I'm only managing their heart failure or their COPD or their transplant, 72-year-old with a kidney transplant. So they won on this one, and they're allowed to have a PCM billable each month. A patient can have both CCM and PCM with different providers, CCM with their PCP and PCM with their cardiologist, but it has to be documented that the different providers are addressing different chronic conditions. And this PCM is subsidized and paid for similar to simple CCM. That's the order of about $40 a month per patient. Okay. The last piece of alphabet soup that I'm going to cover is advanced care planning. So advanced care planning is all of the things that we geriatricians think is so important to contextualize all of these visits and their management and their care coordination. And so advanced care planning started in 2016. And I don't know if you all remember how this got launched, but one of the ways that it got launched was through basically hospice organizations and ARP saying that we need to have a pathway so that goals of care discussions are reimbursed. As you might remember, the word voluntary was mandated because there was this idea. You might remember that there were death panels, and we were going to just all talk to older patients about how they don't want to live or whatever. There was all of this it was very contentious initially. But basically, it finally worked its way out. It was decided to be defined as a voluntary discussion talking about goals of care, and that it was going to be reimbursed not only for the discussion itself, but for all of the forms that go along with that. And the reimbursement was for the first 30 minutes, face-to-face with the patient, or a surrogate if necessary. And this was really something that everybody said, wow, this is really important. And it not only pays for that initial visit, but you could extend it for 30 minutes. It can be billed more than once per year. There's no copay if this isn't done during the annual wellness visit. So that was really something that was pushed as that way. We can get this covered if it's not part of if it's part of the annual wellness visit. And remember, you have to hit the 16-minute point to bill for the 30 minutes. And that's kind of a rule in Medicare, is when they say minimum 30 minutes, they really mean 16 minutes. And I know that that's like splitting hairs, but not really. I mean, it's a pretty important distinction for those of us who are trying to see 6 or 7 patients in a half a day. Okay, so what are the outcomes here? This uptake is actually in the double digits, yay, and it's growing. It's interesting, it's increasingly used. The percentage of uptake is higher in group practices with large numbers of PCPs, not surprising, but more female patients. There seems to be sense that this is an uptick that we are going to continue to see. If you see this graph here, and this is just the latest data, is up to 2019. ACP claims not only freestanding, but those done at annual wellness visits are increasing. If you look at the numbers in a different way, on the percentage of fee-for-service Medicare beneficiaries with outpatient annual wellness visit claims, this is pretty old data, but it's, you know, it's not that old. It's the best I could find. But if you could see the benefit, it's still in the low teens. Here it was hitting 9%, and like I said, probably hitting 15 to 20%, but it's doing a lot better than CCM, PCM, TCM, but certainly not beating out annual wellness visits, since this can be part of the annual wellness visit design. So still single digits, but climbing into the double digits as we speak. Okay. So I talked to you about this alphabet soup of provisions, and I hope that that was not too cumbersome of an outline. I want to stay on time. So now let's just talk about implications for preventative care. So when we talk about implications for preventative care, we have these drivers, right? We have these visits, annual wellness visit, et cetera, address this, address that. But at the end of the day, the big overall national commentary is driven by the United States Public Services Task Force and its grades. So it's got these grades, as you probably know: A recommended, B recommended, C recommended, depending on the patient. D is like not recommended. And then I, which is IETR, FOA, which is there is not enough evidence to make a recommendation for or against. So you are going to see I a lot in the US Public Service Task Force grades, and I want you to keep that in mind. When you look for seniors or older adults in these grades, you'll see 57 hits, but a lot of those hits, especially for seniors, will say IETFR, FOA. Okay, insufficient evidence to recommend for or against. Okay, but we're geriatricians, right? So we know that there are a lot of drivers. Historically, we used to say, well, we'd go with life expectancy with consideration of cognitive issues, dementia. For example, if someone had severe dementia, even if their overall life expectancy was longer, you might want to not do a preventative or proactive measure. And that was always taking into account number of years for something to be given to be a benefit. For example, osteoporosis. You can have a benefit from diagnosis and treatment within months, but say something like colon cancer screening, you might need 10 years to see a benefit. So that was one of the original drivers. Then we said, well, we'll start to use e-prognosis and other calculators. But now we've got these, not only this concept of shared decision making, which of course is important and so important in the context of goals of care, but now we've got these visits going on, annual wellness visits, CCM, CCM. A lot of them have that sort of query in there: is, did you do this? Did you do that? Are you going to do this? So we have a lot of evolution, I would say, on how we think about decision making for older adults, starting with these original, I did this talk maybe 20 years ago, and I had this Excel spreadsheet with life expectancy and then dementia, yes, no. And then we started doing these calculators, and then everyone said you have to do shared decision making, watch this video at least. But now we have these additional alphabet soup of visits, mandated visits that also go into the equation. Okay, so let's talk first about depression screening. We're going to talk about depression, cognition, and falls. So it is now mandated as part of the annual wellness visit. So obviously it's increasingly done, part of many care management protocols. And you can do a PHQ 2 or 9, which is what we do. If you screen positive for a 2, you go to do the PHQ 9, or you can do a GDS, Geriatric Depression Scale. And it's a U.S. Public Services Task Force grade B. And the reason they didn't give it an A is that they want to understand that this is only should be done if you have a plan of management for a positive result. So when you look at the United States Public Services Task Force website, then you see screen all adults for depression, but it's a B grade. And so fair enough, you screen for it. But then when you look at anxiety, which is often follows depression and often is a comorbid concern in older adults, it gets an I statement. And the reason is that they don't have the data they feel to support anxiety screening like they do depression screening. Although they gave younger adults a B grade, they gave older adults an I statement for anxiety screening. So, interesting nuances there because, like I said, a lot of older adults who have depression or cognitive impairment have concurrent anxiety with that. Okay, so what about after the screening? Well, here's why we have the B statement. First of all, there's that copay issue along with the deductible. And if you're going to have a lot of visits, which you often need for adequate mental health, you have facing that copay over and over again. And it may be higher at hospital-based facilities. As I told you, there's the visit fee and then there's the facility fee. And then there's the annual deductible. So and then, although this covers alcohol and drug use, there is a huge, huge lack of mental health providers. So that's the other reason why this gets a B statement is even if you can address the copay issue, the deductible issue, and, the coverage, where do you refer these patients to? Like, where are the providers that are going to provide this type of care? Okay, so what about cognitive impairment? Again, another part of the annual wellness visit. Every year, any person can say that they are concerned, and that is supposed to automatically kick into you doing a screen. However, the United States Public Services Task Force gave this an I. And that is their latest update. They're still giving this an I in terms of insufficient evidence to determine whether there's a benefit for screening or not. Okay, so the screen, as I said, could be any concern, could be initiated by any concern, any observer. You're supposed to, if a positive screen, go down sort of a pathway. And we all know what this is: history, physical, labs. Labs, no more folate because folate is in the American diet. So assuming the patient has adequate intake, you don't have to add folate. That's dropped off. Yes to B12 and TSH. The two things that have been clarified is that syphilis has always been a recommended screen for if there's a risk history, but HIV has been added, as many of you know. There's no specific testing mandated. You can do a mini-cog, MOCA, whatever your group is comfortable with, understands its limitations, and is, has the time to do. And then it does cover neuropsych testing, but interestingly enough, the Medicare reimbursement for neuropsych testing is very similar, whether it's done by a PhD neuropsychologist or a neuropsych technician. So that's something that is very time intensive to get neuropsych testing, several hours, as you know. So that's something clinics are actively grappling with. In terms of where to go from there, CT or MRI is covered. Some of the carriers, especially Medicare Advantage, I don't know if you've had this experience, will deny a CT and just say, just please go to the MRI because they feel like otherwise they're just going to be paying for both. What about scans? Okay, PET scans. So PET scans, as you know, are scans that can be combined with binding agents that highlight A beta, tau, synuclein for Parkinson's disease, they are still only covered for atypical presentations, or if you're in a clinic such as our memory brain wellness clinic, where they are developing pathways for patient management, such as, we're not going to talk about lecanemab, but those kind of clinics can get approval for PET scans. And these PET scans, as you probably know, are increasingly used with ligands that bind A beta or tau. There are multiple now binding agents, and they are where the price point comes in. The basic PET scan itself, which is FDG PET, is only, I say that in quotation marks, 1,000 or 2,000, but these tracers are very, very expensive, and to the order of 3,000 to 5,000 per dose. So that's where the concern about cost comes in, and that's why Medicare, CMS, will cover one PET scan to exclude Alzheimer's disease, but only for patients participating in specific clinical trials or where there's collection of specific data to advance the care of patients with neurodegenerative processes. So then the question becomes, does obtaining these scans, and I'm not talking about CT or MRI, I'm talking about amyloid beta scans or tau scans, change care? Well, as many of you remember, in 2019, there was that JAMA article that said, yes, there are some changes in care, there's situational awareness, people end up having more goals of care discussions. But this is actually becoming touted for many other things. It helps as a diagnostic instrument in enrolling patients in clinical trials. It's basically touted as allowing for care teams to get together and help with patient management. And it's increasingly saying that this is going to be the way we decide whether someone should have lecanemab or not. And so there's a lot of momentum for having a broader coverage of obtaining these scans. Okay. So let's go to the third Geri syndrome that has been broadly appreciated thanks to the annual wellness visit and then the check-in that you're supposed to do during TCM and CCM, et cetera. But mostly the annual wellness visit was the platform for this. And that is gait screening and the concern for falls. And this has been a yes by all accounts. Whether we agree with we don't want to talk about vitamin D here. No one thinks it actually prevents falls, but when you live in this area of the country, I mean, I don't think any of us have seen the sun for the last week. There is a consensus that you should give the basic amount of vitamin D just because we have a high prevalence of vitamin D deficiency. But nonetheless, there is support within the context of the annual wellness visit and some of those other provisions that, along with depression screening, cognitive impairment, gait and falls, is definitely something that you want to do. Okay, so I'm going to take a pause there. And maybe we should make sure that we have enough time for questions. So I'm going to just go on to the other preventative and proactive care provisions. So we've just covered the Geri syndromes that have sort of been highlighted by these provisions. Let's just quickly go after the usual preventative proactive care that are more broadly applicable to the older adult population. Okay. So once again, though, before we do that, let's go over the USPSTF grades. Again, IETRFOA. And for a lot of the older adults that we take care of, like those in their 80s and 90s, and senior care clinic average age is well into their 80s, they're going to get an I statement. No matter what you do, there's not enough evidence to make a recommendation. And that's kind of frustrating, but as I reminded you, there are contexts and pathways for you to decide with a particular patient which one of these preventative and proactive care processes to institute. Okay, so immunizations, yeah, there's some easy ones here. Flu yearly with no now distinction of type with age. And COVID, as new versions released, the standard recommendation is yes. RSV, consider if any risk factors, respiratory syncytial virus. And then Shingrix is a big yes, but it's not covered. So unlike flu and COVID, it is not covered under standard Medicare Part D. Even if Zostavex, you should give this, but cost is an issue. As many of you know, this can be hundreds of dollars and there's 2 shots, and it's only consistently covered under Medicaid and Medicare Part D. So this is something that I'm hoping will be revisited because, as you know, it's got nearly 95% or higher efficacy, and it's efficacious for at least a decade if you do the 2-shot protocol. Okay, those are the easy ones. Here's the tricky ones. I decided that I am going to make a statement about Pneumovax because it is so confusing. So when the PCV20 came out, everybody was like, oh my gosh, what is PCV20? And how does that relate to 15 and 23 and 13? The most common recommendation for our patient population who have already had PSVT 23, which was the old original Pneumovax, and then PCV 13 when it came out, what is it, a decade ago, have already had that. So if they've had both, and it's been more than 5 years since either 23 or 13, then yes to 20. Done. That is the most common scenario. So I decided to highlight the most common scenario. Otherwise, you get all tied up in the various algorithms that no matter how many times you look at them, I can't understand them. Hepatitis A series, if at risk. Hepatitis B series, if at risk. So hepatitis A, if you're going to be traveling to a country that has a high level of hepatitis A prevalence, and then hepatitis B, if your older adult decides that they're going to go work in an area where hepatitis B is prevalent. For example, if they decide they're going to start working in medical care, they should have a hepatitis B series if they have not already. So that's that. And I will take questions regarding vaccinations at the end. Now, what about other infectious disease? The big one that I want you to know is hepatitis C virus infection screening is now 18 to 79 years of age. Everything else is sort of, if you're at risk, HIV, Hep B, syphilis, tuberculosis, but it is now a national recommendation that you screen patients up to 79 years of age for hepatitis C screening. And it was based on birth date, and now they just gave a standard age. What about other things? DEXA, yes to DEXA. What bothers me, and I think the VA has probably come a long way from compared to Medicare, is this statement that there's insufficient evidence to screen men. But women, it's an absolute yes. At 65 and older, DEXA is 100% covered. It's part of the recommendation across the board. But this comment about insufficient evidence for men, I think is a little bit bothersome. And I know the VA has come around to recommending DEXA for men, of course. And I do not believe that there's any requirement for a second risk factor. Medicare requires that men have a second risk factor besides being 65, and that can be steroid use, it can be androgen deprivation therapy, but smoking doesn't count, diabetes doesn't count, alcohol use doesn't count as a second risk factor. So I find this frustrating. Okay, AAA, this has been in place for years. You see the age, basically, you're going to screen most men up to age 75. So that's an easy one, and that's been in place for a long time. Okay, what about lifestyle? This is, I think lifestyle, I'm a big proponent of healthy lifestyle. The big one that I think we do not appreciate, because I think we're all appreciating alcohol, depression, we've already talked about, hypertension and weight. Yeah, that's sort of a given. But I think the big push now that I've seen over the past 10 years is that no matter how old your patient is, you should continue to push tobacco cessation if they are smoking. And that includes oral tobacco as well. This is something that has really been in the literature more and more, is you should not give up on your older patient who's a smoker or a tobacco chewer. There is a benefit to stopping, and that we should pursue this irrespective of how old that patient is. Okay, so pause here to reflect on that. Okay, so then the question is, the elephant in the room is primary prevention, right? So the big two are statins for primary prevention of CVD, cardiovascular disease, and aspirin for primary prevention. You know what you've heard, which is insufficient evidence after age 75 for statins and insufficient evidence after age 70 for aspirin. It's kind of funny, you know, it's like 70 here, 75 there, but that's where the data stands as of now. My problem with this is that the new CVD risk calculator, which is going to be in this talk and which you can easily get to for looking at 10-year risk, does not talk about brain risk. And as someone whose research is grounded in brain vascular biology, I have a little bit of a concern about not taking that into account. But the CVD risk calculator has been updated by the American Heart Association so that for patients with a high CVD risk, you can still consider aspirin and statins. But again, after age 75 for statins and age 70 for aspirin, they're still going to give you an I statement, even if the patient has a high cardiovascular risk score. Okay, breast cancer, here we go. Mammography after 75 is not evidence-based, so you should consider stopping it. Insufficient evidence starting at age 75, so it has to be within the context of the patient. And it's just, you know, like I said, there's 70, 75. Colon cancer is up to age 85. So this is, you know, this is very, I think, a moving target. And I think this is where having these guidelines are great. But at the end of the day, I think each patient has to have a separate consideration for the things where some things are up to age 70, some things are at 75, some things are 80, and now for colon cancer, it's moved up to 85. Okay, what about prostate? Well, you all know about that. It got a C recommendation for younger men, and then an absolute D, which means do not do, for men 70 and older. But there's now data saying, well, you know, there's some men who are like dying of prostate cancer and actually dying of the cancer rather than dying with the cancer. And maybe we need to revisit this as men live older and older. And we've now got MRIs for prostate, and we've now got some strategies to also better stratify who's going to have a high risk cancer that requires intervention versus watchful waiting. So watch out for this. It's being updated for 2024. And I look forward to this because I think those of you who, you know, just follow the news, there are just a lot of men in their 70s who are reportedly dying from prostate cancer. And I think we need to be aware of that. Okay, lung cancer screening, here's another one, up to 80. So this moved from 75 to 80 a few years ago. And it's, as you know, people who have quit within the past 15 years. Okay, lots of other things to consider that have intermediate levels of evidence. I just listed them here as a way to have a reference value. Okay, now we get to some easy stuff. I just want to quickly review the documentation changes that have all of this sort of came out of the Affordable Care Act. Okay, so yes to left for documentation. Yes to medical student documentation, just write the correct attestation. Yes to total time-based billing, now available to all for outpatient and inpatient for that day, total time for that day. And if you're going to work with learners, as you know, total time doesn't usually work out because they've done most of the time. So you still have to think about using classic E&M codes when you're attesting for learners. And then rather than total time. And then the big kid that hit the block January 1st of this year was G2211 for ongoing relationship with the patient. This has a $16 value. Yay, so it'll pay for your lunch. But used with E&M or total time-based billing. It can be used for residents. I know one of you asked this question. because it is almost certainly your patient, your ongoing relationship, but likely cannot be used for fellows because fellows have their own template. You're saying that the fellow is really the driver of that patient's ongoing relationship. So G2211 can almost always be used for a resident and certainly a medical student attestation, but likely not for fellows. So good question, whoever asked me that one. Okay, telemedicine, well, you know the drill. It's here to stay. You still have to consent. Everything is in place under the COVID provisions through the end of this year. Again, through the end of this year. Who knows what's going to happen in 2025? That means that after this year, there may be some requirements for site-specific and geographic restrictions. For example, our relationship with Alaska. Audio only, again, through the end of this year. I'm not sure how they're gonna look at that for next year, which is phone call only. And then again, through this year, everything is in place for hospice eligibility, hospital care at home, etc. So stay tuned for what might be more restrictive in 2025. I suspect phone visits will still be allowed because it's such an equity issue, but I suspect that there'll have to be more documentation of why you're doing telemed or telehealth and not seeing the person either at home or in some other face-to-face encounter. Okay, e-medicine, yay, e-medicine. Well, it doesn't really work for geriatrics, but e-consults now pay the requester as well as the responder. It now pays for specialist to specialist consultation. But what's unfair here is the responder only has to place 5 minutes, but the requester has to spend 30 minutes. And again, 30 minutes is always 16 minutes under Medicare, minimum of 16 minutes. But it's a little, so requesters have not been using this code, at least in UW medicine. Responders have been using the code because it only requires 5 minutes. But the 30-minute requirement for requesters, i.e. 16 minutes, has really been hard to meet that bar. Okay, so last but not least, what is going on with all of this and the term MACRA? And what is MACRA? And who should I care? So MACRA is the Medicare Access and Chip Reauthorization Act of 2015. It was bipartisan legislation. And it basically said, we need a quality program for physician reimbursement. And it rewards clinicians for value over volume. And it is accelerating as we hit 2024. And there's 2 ways to do it. It's either merit-based incentive payments, which is big practices, or smaller practices can take on more risk for higher rewards and use what's called alternative payment models. UW is doing merit-based incentive payments. What does that mean? Well, merit-based means that instead of seeing multiple people multiple times, as many times as possible, you're going to look at these 4 parameters. And over time, these 4 things have changed in their relative importance in calculating reimbursement. So there's quality, which is readmits and patient experience surveys, cost in terms of like bundled payments for like hip replacement or knee replacement. Interoperability, which is the use of obvious electronic records for order writing and prescriptions, and then pop health. That's a big one. Expand access, make sure you have templates that allow patients to get in, and population health measures, including vaccination, hemoglobin A1C less than 9 for your diabetics, blood pressure parameters for patients who are hypertensive. Those are those pop health initiatives. So where does that put us? Well, we're doing MIPS. That's part of what most large academic practices do. And here's the percent for 2024. So this gives you the relative amount. You can see cost is 30%, quality is 30%. Improvement activities, and interesting, improvement activities are only 15%. And then interoperability, which most places have already done, which is, electronic medical records, electronic prescribing is 25%. So it's a little interesting. I thought that for 2024, improvement activities would go down and promote interoperability would go, improvement activities would go up and promote interoperability would go down, but that hasn't happened yet. So we'll see. This is something though that all academic practices that have large Medicare populations have to pay attention to. Okay, so let's go over the summary and we have time for questions. So the Affordable Care Act is the origin of many provisions that have resulted in attempts to improve the care of older adults. We don't quite know if it's all done that, but that was the goal. Annual wellness visits, transitional care management, complex care management, and advanced care planning are here to stay, and they'll be increasingly required. Depression, cognitive impairment, and falls are called out yearly in the annual wellness visit and also are sometimes put in as part of the care plan for, say, complex CCM, and are always part of the consideration for advanced care planning. So, in terms of other things, though, do screen for Hep C, immunize and don't forget Shingrix, screen for osteoporosis, never too late to stop smoking and improve lifestyle. Consider primary prevention, statin and aspirin in context of brain health, as well as the new CVD calculator, which I put into this talk. I don't know why it's not even. Oh. Do screen for breast and colon, and just keep in mind that whether it's 75, 80, or 85, I think that it has to be in the context of the goals of care of that patient and their overall comorbidities. Screen for AAA and lung cancer if meet criteria, but again, these criteria are tough to follow sometimes because the age ranges are not consistent. Prostate screens will be updated soon. The do not screen decisions need to be in the context of the patient and their goals of care. Streamlining documentation started in 2018, accelerated with COVID, and is here to stay. And I don't want to give credit to the previous administration, but the streamlining has been very helpful. Billing by total time and add-on G221 are designed to support non-procedural work, which has been a big bonus. We'll see how G2211 evolves. Telehealth continues to be reimbursed. Payment codes for eWork are expanding. And stay tuned for our data on how much simplification of documentation will help providers and encourage providers actually to take on more older adults in their practices. MACRA and similar programs to prioritize and reimburse quality over volume are ongoing and here to stay. And you can see those 4 metrics for quality. And most large organizations have automatic mechanisms in place so that you don't have to worry. But occasionally you do get reminded on doing this or that or checking off that box to not only avoid penalties, which are coming into place now starting last year, but also there are bonuses for meeting certain criteria. And it'll be very interesting to see whether academic practices can get those bonuses, because we have a lot of drivers of inefficiencies, as many of you know. And that's it. And we have plenty of time for questions, which was my goal. So let's see, shall I start with the chat, Kate, but please fill out your peer review.
Yes, yeah, there are lots of questions in the chat, so I think there'll be plenty to talk about there.
Okay.
You might have answered some of these questions already as the talk went on, but there are quite a few there. And yeah, please fill out the evaluation for May so that she gets plenty of teaching evaluations today.
Thank you, Kate. Yeah, so Amy Thomas asked, how did cognitive screening get added to the annual wellness visit? Yes, United States Public Services Task Force level I, meaning insufficient evidence. Yes, Amy, that was a political thing. ARP, Alzheimer's Association wanted it. And it got added from those drivers as a parallel with the hope that the USPSTF would eventually change their recommendation, because they only meet like every 3 to 4 years because they're addressing like 100 things. So like every 5 to 6 years, they will do an update on a particular topic. Angela wanted to know for CCM and complex CCMs, what happens if you miss a month? Yeah, you don't bill for that month. Yeah, good question, Angela. Yeah, but people are just like trying to figure out how to set that up, but so that there's a reminder to bill for that month. But yeah, you just don't bill for that month. You can come and go my understanding. And then Amy Thomas was wondering if what maybe Angela could answer this. Are PET scans being done at Harborview, a memory brain wellness clinic? Are they using PET scans, or are they just sticking with MRIs in their lecanemab patients or other patients who are entering clinical trials?
I think I will turf that to Dr. Rosenblum, who's giving a grand rounds. It's a very long topic.
Yeah. So Amy, the qualifiers for lecanemab are clinical and then MRI. And then frequent MRIs after that. So PET scans are not required to give lecanemab. So my understanding, and Angela's right, this is a moving target. So right now, PET scans are not required.
Yeah. And maybe just to clarify, so FDG PET, I mean, I think non-memory brain people and VA like can order those things. I think what you're asking about is amyloid and tau. Moving target, it's not for you to order. So let us do it for now. I don't even think we can order them. It's a moving target. Right now, we're still doing LPs to prove amyloid.
And the next question, why is Shingrix not covered except under Medicare Part D and Medicaid? Good question. And I think there's some evidence that Zostavax still has efficacy in the 50 to 60% range, and that was covered back in the day, 15, 20 years ago. But yes, everyone is wondering the same thing. Sophia, what were you wondering about MASLD?
I believe that that's an indication for vaccination against hepatitis A and B.
Oh, correct. Yes. MASLD, for those of you who knew it as NAFLD, is metabolic associated steatotic liver disease. It has replaced NAFLD, which used to be non-alcoholic fatty liver disease, as the correct classification for patients with metabolic associated liver disease. And you're right. Yes, that is another indication for getting full hepatitis vaccination. Good point. Pneumovax, yes, Carrie. Yes, we have a beautiful diagram on our senior care clinic. Thank you for the link. I just decided that I would look at senior care demographics and just call out the most obvious need, which is PCV 20 for those patients who are more than 5 years after 23 and 13. Okay, pointed out that men should have osteoporosis screening, and that the VA, actually, she's not sure about the national VA, but the local VA does screen men starting at age 65 without that second risk factor. But Medicare has still not changed that. You still have to document a second risk factor. I don't want to be sneaky about this, but one that, you know, works is saying that they have evidence of osteoporosis, or no, you can't say osteoporosis on a regular bone x-ray, but you can say like compression fracture or something. Anyway, just saying that there are imaging criteria that do give men that second risk factor. Kay was saying, yes, it makes no sense that, yes, but just a reminder though, under Medicare, tobacco and alcohol and diabetes are not considered adequate as that second risk factor. Crazy, but true. Yes. And then Angela is saying, agrees with me as a neuroscientist that you have to think about when you think about primary prevention with statins and aspirins, and you only do the CVD risk calculator, which is cardiac based, you have to think about whether this patient has evidence on MRI, even if they haven't had a stroke, because obviously if they've had a stroke, then it's secondary prevention and you're in good shape. But if you get a patient whose MRI, they have a little cognitive impairment, you get an MRI and you see vascular evidence of white matter disease and maybe some white matter hyperintensities. Yeah, that's what I'm saying. Like there's a patient where it wouldn't technically be secondary prevention, it would still be primary prevention, but if it was my brain, I would want aspirin and statin. Elizabeth wanted to know intensive behavioral interventions for obesity. And yes, Elizabeth, that is the whole lifestyle world is just really impacted by the fact that there are a huge lack of providers for that, but they mean basically exercise, aerobic exercise 5 times a week. And then a diet as mandated by, you know, low carb, healthy diet type things. It's pretty aggressive. Yes, patient priorities, 2211. Yes, 221 is an add-on billing code, Amy, for patients who you have a longstanding relationship with as an add-on to EM or time-based billing as an outpatient. And I don't know if the VA needs that. And then Kate pointed out that, yes, under the Inflation Reduction Act, recommended vaccines that are not covered under Part D must be covered under Part D. Yep, yep. So Shingrix is covered under Part D, but the key, I think, will be to see if we can get Shingrix covered under Part B. And then, yeah, so what did I recommend for each of my case patients? Yes, so I went all out on patient A, which was the lady who has really a life expectancy calculator and who's functionally independent. 15 years, I recommended all of the above, including mammogram and colon cancer screening. And my other patient, the very frail patient whose life expectancy was 3 to 5 years, I just recommended the vaccinations and osteoporosis screening. Yeah, and sorry I didn't finish up with those. I didn't want to run out of time. Thank you for all these wonderful questions. Please fill out your evaluation, and I think we will stop there as it is 9:01. Please email me if you have any other questions. And thank you again for your attention.
Thanks, May.